Awesome, 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 awesome. Hey, Barry did a great job, Ross, and I can't wait to see what you have in store for these case studies, man. So I'd like to introduce Ross Workman, CPO. Ross is a seasoned CPO with over 20 years experience in orthotics and prosthetics and over 25 years in the rehabilitation field. Ross has worked as a physical therapist for the Department of Veteran Affairs before moving into orthotics and prosthetics. So I'm going to just turn it over to you, Ross, and take it away, my friend.
Thanks, Rich. Good to be with you guys this morning. Barry did a great intro segue into what I'm going to cover, which is some case studies using carbon composite AFOs and specifically solving sagittal and coronal plane deviations using carbon composite AFOs. So first of all, I just got to say that there is a disclosure statement that I do work for Hanger Clinic. I'm a manager and I'm a paid employee of Hanger Clinic and I receive a salary. We'll get that out of the way. Just a kind of little overview of what we're going to cover today. We're going to talk about normal gait, some of the things that impede normal gait. We're going to look at some common abnormal gait deviations for a lot of our patients that we see. We're going to look at common etiologies treated with AFOs. We're going to look at some of our orthotic treatment options. And then we're going to move into the case presentations. And then we'll do a summary of everything that we've kind of looked at today. So when we talk about composite AFOs, there's several different categories. This whole pre-preg carbon thing kind of started with Ryan Blanc back at the Department of Defense when he developed the IDEO brace, which Ryan now works for Hanger Clinic. And we are using the ExoSim name, which is our version of that brace. So you can see up here, there's several different designs based on patient presentation and what we're trying to achieve with these patients. A lot of these braces are working in just the sagittal plane. Some are working in the sagittal coronal plane. But today we're going to look at this one over here at the far right. This is Custom Composites version. And this version is actually, and this is just one of the many designs. I believe Barry has like 10 different designs. And we're going to look at some of the different designs and how you can better use those to help your patient population. So when we talk about custom composite or carbon AFO pre-preg, they're typically energy storing orthoses. And it's typically fitted external to the leg and the ankle and foot, designed to harness ground reaction forces to replace or augment multiplanar function of the ankle and also stabilize the knee during stance. So some of the examples that we see were ones that we saw on the previous slide, the IDEO brace, which is by the Department of Defense, the ExoSim, which is our Hanger's version of that brace. There's also the Helix, the Fat brace. Kinetic Research has the Noodle. Custom Composite, which we're going to focus on today. FabTech has their PDE Element, which basically uses a dynamic strut. And typically the calf and the foot section are a wet layup carbon. And then the Vector. So these are kind of some of the braces that are out there. So what are the indications when we are talking about prescribing for a custom carbon energy storing and returning ankle foot orthosis? Well, basically, the patient presents with impaired gait due to pathology, which is improved and or correctable with a custom ankle foot orthosis. The patient has realistic goals and a realistic potential for improved ambulation or gait, and they're unable to achieve goals with a custom fit fiber AFO. And when I'm talking about that, I mean basically like your off-the-shelf carbon braces, which would be the Noodle brace, the Allard toe-off brace. Autobach has a walk-on. Townsend has the Spry Step. So basically patients that can't meet their goals with these off-the-shelf braces. And also they're unable to achieve goals with conventional standard AFOs, which when we say conventional and standard, we're talking about plastic or hybrid plastic and metal. So when we talk about coronal sagittal plane deviations, most of our patients, I would probably say at least 75% of our patients present with deviations in the coronal and sagittal plane. So the coronal plane, for those that are not up to speed on this, is basically your medial lateral deviations. If you're looking at the hind foot posteriorly, that the hind foot is typically in a varus or a valgus position. So figure A would be a valgus position, figure B would be a varus position. So basically your weight line has shifted and it's causing gait difficulty. Your sagittal plane deviations, a lot of times we think of sagittal deviations as being weakness in the anterior posterior direction, but it can also be tight heel cord, which will either cause a plantar flexor contraction or a muscle imbalance. And some of these things actually impede gait more just because they don't have a full range of motion in the sagittal plane. So we're going to talk about how we can address those issues using composite AFOs. So some of our common diagnoses that present with both sagittal and coronal plane deviations, there's many. This is not by any means an exhaustive list. These are patients that I've fitted. There's probably several more, but CVA, spastic diplegia, which would be cerebral palsy, Charcot-Marie tooth, posterior tibialis dysfunction, incomplete paraplegia, MS, multiple sclerosis, TBI, nerve damage, arthritic orthopedic injuries, polio, and Charcot deformities. Now, I've seen many people that don't have this specific diagnosis that qualify, and it's basically up to the clinician to evaluate and assess what those deviations are and how to better correct those. So when we talk about correcting these sagittal and coronal plane deviations, one of the things we really need to focus on is our 3.4 system, which is critical in restoring natural alignment and restores motion in the sagittal plane. So here you can see, excuse me, a diagram of a patient with a valgus deformity. So basically, your axis there is right above the malleolus. And so what we need to do is we need to apply a corrective force, which would be the arrow moving to the left on the right-hand side. And then we need our counter forces, which would be the two arrows on the left-hand side pointing right. So the idea is that the longer those corrective forces are, and with a properly placed corrective force on the right side, we can restore that alignment and get the foot to work in its natural sagittal plane, which is what we're trying to accomplish. So what we're going to do here is we're going to look at these case studies. I'll go ahead and we're going to read how they present. We'll watch a video of them walking, and then we're going to talk about the brace description. So this patient is an interesting patient. He's congenital CP. He's 63 years old. He actually lives on a golf course and is a groundskeeper. And so he's very active out on uneven ground quite a bit. He came to me, he was wearing conventional plastic solid ankle AFO. He was having quite a bit of problem with skin breakdown of the base of the fifth metatarsal just because he was in so much varus and walking on the lateral border of the foot. So his heel was in varus. He had calcaneal varus. Forefoot was in supination. He had a tight heel cord from being in this position for so many years, so he's basically got a plantar flexion contracture of 5 degrees or minus 5 degrees of plantar flexion. And he also has varus moment of the knee during stance and poor balance. So what we're going to do here is we're going to talk about the brace design. So what I basically did here was used a varus strap and a medial strut. So if you look at that picture, you can see the strut runs medial with a side opening where he could come in through the lateral side to get into the brace and leave the brace in the shoe. So I did a varus strap. We actually integrated the heel lift to neutral on a 3/8 inch heel to bring the floor to him. And then by using those corrective forces, we could actually pull his heel into a neutral position. So we ended up getting better balance, an equal stride length, and decreased pressure on the base of the fifth, and that callus basically went away. So this one we're going to look at a patient from the Philippines.
Okay, come back.
This patient was previously undiagnosed. He came to the U.S. He was adopted by a sponsor family. He had never been diagnosed. He had a leg length discrepancy of 3/8 of an inch on the left, which initially I did not address until we braced him. He had 0 out of 5 dorsiflexion of the ankles and -5 degrees of dorsiflexion of both ankles. He had uncontrolled varus instability. You can see that his weight line was shifting. He had exaggerated trunk lean and poor balance, varus of the knees during mid stance, and was very painful walking on the lateral border of the foot.
Okay, go ahead.
So what we did here is we did medial struts with varus straps. We built up the heel cords. In this video, I had not addressed his leg length discrepancy yet, but you can see his gait has smoothed out dramatically. And actually, I'm asking him to walk a little bit faster here, which he had not been able to walk at more than a self-selected speed until we were able to brace him here.
Okay.
So here he is with the leg length discrepancy accommodated with his braces. You can see that his coronal alignment is restored. Sagittal alignment is corrected by bringing the floor to the patient. He's got a decreased compensatory moment. He's got better balance, and his walking speed is much faster than it was before.
Good job. Go ahead.
So here we have a 26-year-old male with congenital hemimelia, which means he's fibular absent. He's plantar flex 5 degrees because of a tight heel cord.
So it doesn't necessarily hurt every step without the brace? No. Okay, it's just afterwards. Okay.
He's in calcaneal valgus. You can see he's got a pelvic obliquity because of the pronated foot. And he's actually wearing 3/4 inch heel wedges due to a functional leg length discrepancy. So he doesn't complain of pain too much except for when he's on the foot for extended periods of time. But you can just see on that finishing video right there, the right foot that's forward, you can see in how much pronation he is just because his heel can't reach the floor and he's pronating excessively. So using our 3.4 system, we're gonna brace him with a lateral strut and a valgus strap, which would pull him into a more neutral position. And we'll look at that one. So there's his brace.
Go ahead and walk.
So we brought the floor to him, and we used a valgus strap there.
Go ahead and come back.
His gait really didn't change a whole bunch, but you'll notice that the alignment is corrected. He's able to wear the brace longer during the day.
He's able to feel a little short.
He's able to be on his feet longer without complaining of pain.
Okay, go ahead.
And I don't know if you heard him mention there, he feels like he's standing straighter. So we've addressed his low back pain and his pelvic obliquity. So this is a patient with a crushing nerve injury. He came to me wearing a solid ankle AFO. You can see there he was doing a step 2 gait because he's in so much pain.
Go down about that far and come around, come back.
He's got hyperextension of the knee because of the tight heel cord, the plantar flexion contracture. He doesn't trust the leg. He's not really getting any tibial progression. So he's got a whole host of problems here. So it's interesting to note that I could not get him completely to neutral. But what I did was in my cast, I corrected his forefoot adduction, tried to bring the heel as close to neutral in the coronal plane as much as I could, and then basically just brought the floor to him. So we're going to use a medial strut, a lateral with a Varus strap on him. And this is what he looks like. And just want you to listen to what he says.
Oh, wow. I'm not even feeling that pressure point this time for some reason.
On the outside part of your foot where the callus is, go ahead and make one more trip.
Yeah, it's like crazy.
Perfect. Go ahead and come back.
Yeah, this is nice. I'm surprised at how much strength it feels like I got.
So you can notice by what he says there, first thing he says is, wow, he's able to just load the leg. And the second thing he says is, I can't believe how much strength it feels like I have. So basically what we did here, other than the brace design, is we ramped the toe plate for a rocker effect because he really didn't have any true sagittal plane motion because he's in 5 degrees of plantar flexion. So we brought the floor to him and we reduced the Varus ankle moment at the ankle, the Varus at the ankle. So basically what we've done is we've created an equal stride length, an increase in gait velocity and stability during dance phase. And the added benefit to that was the lateral border, the pain of the foot on the lateral border was eliminated. So he was actually able to walk comfortably all day without having a callus or pain on that side.
Okay.
So lastly, this is a patient that I saw just about a week and a half ago.
And you feel like your knees are going to buckle?
No, not on this floor.
Not on this floor. Okay, one more time.
So he's in a severely pronated position. He's got some sagittal plane instability.
Okay.
So we're not quite sure what he has. They're basically
You have to grab onto stuff for balance?
Yeah.
We're trying to rule out MS versus ALS. So you can see that he's in a severely pronated position with calcaneal valgus and forefoot adduction, and that's because the lack of dorsiflexion, he has no dorsiflexion at all. So his heel cords are tight, which there in turn causes excessive pronation. He's got 3 out of 5 plantar flexors. His knee extensors are fairly weak, 3 out of 5. So he's got kind of a crouch gait and poor balance. And he came to me and he'd been falling. He actually he's a musician and plays in a band and was playing an outdoor concert and actually had to sit on a stool because he could not stand for more than 15, 20 minutes at a time. So for him, what we're going to do is we're going to address that sagittal plane by putting the shell instead of posterior, we're going to put it anterior to give him some ground reaction forces. And we are going to do a lateral strut so that we can pull that heel into a more neutral alignment from his valgus pronated position that he's in.
Ready?
We're ready. Go ahead. You can turn around and go back one more time. I think you got more proficient just in the hour you were gone.
Well, walking around Fred Meyer was like, this is pretty cool. It almost feels.
So here, based on, you can see his reaction, he walks much better. He's got some good knee stability based on that floor reaction design that we used. There's decreased compensatory motion, so he's not getting extra trunk sway and balance issues. We've increased his gait velocity, equal stride length on both sides. And you could see there that he's got some increased patient confidence. So he's not, when he came to me, he was kind of doing the put your hand on the wall and grab things as he was walking. Here now he's just walking independently and not having to worry about balance or falling. So what are the keys to bracing when we talk about using custom composite 3.4 systems? So the first thing we want to do is we want to identify sagittal, coronal, and transverse plane deviation. So you really want to look at your patient and identify which deviations they have and which ones you want to identify and correct primarily. So, sagittal would, if you drop foot or coronal transverse planes, you're going to look at that and pick your brace design based on those deviations. Secondly, you want to choose your appropriate 3.4 application. And as we looked at the slide earlier, so you always want to put your strut on the opposite side of the deformity. So if that would be a valgus deformity, you're going to want to put your strut lateral. If it's a varus deformity, you're going to want to put your strut medial. And you can choose your calf design. Barry has a couple different designs. You can choose that side opening, anterior or posterior, depending on how bad your sagittal plane deviation is. So a lot of times I'll put my calf band posterior if people tend to hyperextend to try to block that. Or if they've got a crouch gait, I'll put that anterior so that we can get a little bit of ground reaction force and give them a little bit better knee control. Thirdly, this is really important. If I could stress this, I would really stress this a lot. basically what you want to do is you want to correct these deviations in your casting technique as much as possible. So I like to hand cast. I know some people scan. We'll talk about the different ways to do that. What I like to do is basically cast and correct my hind foot position first, and then bring my foot up into a neutral dorsiflexion position if possible. So typically what happens with these people with tight heel cords is if you hold the calcaneus neutral and you bring the foot into dorsiflexion, once you reach your end range of your Achilles, the foot will tend to fall into either a varus or valgus position based on the weakness or the tightness of the Achilles. So I bring it up until where I start to feel resistance, and basically that's where I cast them in that position. And if they are in a little bit of plantar flexion, then I just I build up the bottom of the brace itself to bring the floor to the patient. So that's really important. You want to make sure that you get these corrected as much as possible in your cast, so that your outcome obviously is much better. Lastly, you can choose your band configuration based on sagittal plane deviation. And for example, you can place your band anterior, posterior, or side opening based on your sagittal plane deviation. A lot of times the patients I see are CVAs or they have upper extremity involvement. So sometimes getting into a posterior calf is a lot more difficult because the brace is already in the shoe. So sometimes I'll do a side opening just so the patient can get in a little bit easier using one hand if they've got problems with manual dexterity. So what are the advantages to carbon composite? I know Barry talked a little bit about some of the costs of using plastic. Well, here's 10 advantages to carbon composite bracing. First of all, it's patient acceptance. Patients love these braces. They tend to weigh 6 to 8 ounces, which is very, very light. And they tend to fit in just about any shoe. Because it has a molded footbed that you can trim, basically you just remove whatever insert comes with the patient's shoe and replace it with the brace, and it fits really well. 2, there's highly modifiable design options. I think there's 10 different designs. So basically there's a design to fit your patient based on your assessment. With that said, Barry has done some custom designs. If you don't see one there and you have questions, just call him and he'll make a recommendation based on your patient presentation. The open design allows for patients with volume fluctuations. A lot of these patients have other comorbidities such as peripheral vascular disease or swelling or cellulitis. So the open design, because you're only doing a strut typically on one side, gives the leg plenty of room to swell and the brace continues to fit. You don't have to make adjustments for those volume fluctuations. The molded footbed allows for further control and increased comfort. Because the molded footbed is made to your cast, basically you can correct ground reaction forces, and it's like having a custom foot orthotic in your brace, and it's adjustable as well. Like we talked about, it's lightweight, 4 to 6 ounces in most cases. Some of them are 6 to 8, depending on the amount of carbon in the layup. And what I found is that there's minimal follow-up and adjustments due to this open design. So basically, when you use plastic, a lot of times people will rub because it's more enclosed. There's more chance of areas to rub and to heat and adjust. And so with these braces, what I found is I typically don't have to do a lot of follow-up, maybe replace straps occasionally, but the actual brace itself doesn't need to be modified very rarely. It's able to fit in a variety of shoes due to less bulk than plastic. We talked about that. Dynamic properties, like Barry talked about, depending on the layup, we can make the brace very rigid in certain areas where we need rigidity and strength. And we can make it flexible in other areas like the toe plate so that when the patient does load the toe, they get a little bit of propulsion at late stance, which actually just improves gait. Layup is individualized to the patient weight and activity level. So Barry touched on that a little bit. So if you have a patient that's pretty heavy, that's over 250 pounds, you can do layup customized to their weight and activity level. And lastly, patient compliance leads to better long-term outcomes and happier patients. So we've all had those patients that come back in and they got their brace in their hand, or it's in the closet. What I found is because these braces are easier to wear and they're able to be fit in a variety of shoes, they tend to wear them longer and more frequently, and that leads to better outcomes. So how do you get your cast to bury, and how do you get your brace made the way you want it? Well, I've listed 5 different ways that you can do it here. The first one is you can take a corrected hand cast in plaster or fiberglass and send it straight to Custom Composite for fabrication. Basically, you're going to just try to correct everything in your cast, and you send your negative model, and they will fabricate that brace design for you. Second, you can take a corrected hand cast and fill it. This would be in a case where you're not able to correct as much as you would like in your hand cast, so you're going to pour it and fill it and maybe wedge it, do whatever you need to do, and then make your modifications, and then wrap that corrected positive cast and then send in your wrap cast. So that's another way to do it there. Number 3, what I typically do, I do number 4. Number 3, you're going to take a corrected hand cast, pour it and fill it, and then you can actually scan your positive model for those that have a structure scanner like TechMed or whatever scanner you may have. You're basically just going to pour it, make your modifications, smooth it all up, and then actually you're going to just scan your positive model and then send that scan for fabrication. That way you've made all your necessary adjustments and corrections, and you're just basically scanning that positive model and sending it out for fab. Number 4 is what I actually do. I take a corrected hand cast, I correct it as much as I can in my negative, and then I actually scan the outside of the cast, and I send that file to fabrication. It's important to note here that you're going to want to write down what material you used and how thick you used it, because whoever's fabricating for you is going to have to compensate for the thickness of the material. I typically use C-form, ST&G C-form, and I use 1 roll. So it typically ends up being about 1/8 of an inch reduction. So based on what you're going to be using and how thick your cast is, you're going to want to make sure that fab knows what you used and how thick it was so they can compensate. Lastly, you can scan directly to the patient's limb and send to the fab. I have the ability to do this, but what I found is a lot of these patients that have multiple plane deformities, when you're scanning directly to their limb, they're sitting on a platform, and you're unable to scan and correct at the same time. So what's going to happen is you're going to get a scan of the patient's limb in the deviation that they have, and then what's going to have to happen is when you send this out for fabrication, they're going to have to actually correct it in the system. And so for me, I like to have better control because I know the patient, I can get hands on them, I know how much I can correct. Sending it out to a lab that they don't know the patient, they've never put their hands on them, they may not be able to correct that in the system, but that is an option. And obviously scanners are meant to scan directly to the patient so that you can get a better capture of their anatomy. And I will say that the way that I do it, basically I hand cast, scan the outside of the cast, and I'll scan it same day, and then I can email that order, and it typically gets there the same day, and Barry is usually able to turn that out in about 2 days and get it back to me second day. Now I'm in Washington and he's in Rhode Island, so I'm able to get these braces back in a week, which is really reasonable. So in summary, we have several different composite options to choose from. You can get that from the Custom Composite site. You're going to want to match your orthosis function to address the pathology of your patient. Capture the anatomy in the best corrected position possible. I think I've stressed that you really want to correct those deformities in your cast as much as you can. And then with AFO designs such as Custom Composite, you're always going to want to place the strut on the opposite side of the deformity. And lastly, you're going to want to address patients' mobility goals. That's going to be the most important. Some patients just want to be able to be community ambulators, walk to the grocery store, go to their appointments. Some other patients are going to want to be more highly active and do maybe a little bit more. Maybe they want to run, maybe they want to hike. So you want to make sure that you bear in mind all of those things as you decide which brace design you're going to use. So that's it, basically. If you have any questions, I'm always available to answer your questions. My email is here. And you can email me at any time if you have any questions regarding brace designs or basically the process. So thank you very much for your time. It's been a pleasure to be able to share some of the experiences that I've had with you today. Thanks.
Absolutely. Ross, thank you so much. Extremely informative. Some amazing case studies. And I'm sure that all the attendees saw the value of the use of carbon composite AFO. So I really appreciate working with you, and look forward to another event together, my friend.
Thank you.
All right. Be well.